Hi guys, today we are discussing about bronchiectasis. So what is bronchiectasis? Bronchiectasis is nothing but the abnormal dilatation of bronchi and bronchioles with destruction of bronchiolar walls. It's nothing but it is an abnormal permanent dilatation of bronchi and bronchiole with destruction of bronchiolar walls. What are the causes? Number one, we are seeing the Gardner syndrome. So Gardner syndrome. What is this? Gardner syndrome is primary ciliary dyskinesia. Means what happened? There is nothing but immotile ciliary syndrome. Immotile cilia syndrome. Okay. Gardner syndrome is the immobile cilia syndrome, or it is also known as the primary ciliary dyskinesia, which is also responsible for the male and female infertility. Okay, male and female infertility. So there is triad. There is one thing where we can see the Gardner syndrome. We can see the Gardner syndrome in three conditions. One is the bronchiectasis and situs inversus, that versus, and third one is sinusitis. Second cause is cystic fibrosis. Cystic fibrosis is responsible for bronchiectasis and immunodeficiency state. Cystic fibrosis and immunodeficient state. Third one is the bronchial obstruction. Fourth is the infection. What kind of infection? Necrotizing or suppurative? Necrotizing or suppurative pneumonia. Suppurative pneumonia. It usually affects the lower lobe of lung. It usually affects the lower lobe of lung. And what is the pathogenesis? In pathogenesis, we will see there is a obstruction which is caused by the foreign body. Okay, it could be the foreign body, for example, and which causes the or impairs the clearance. So there is a problem in the clearance of bronchial secretion, right? And which is then responsible for the favorable substance for superimposed infection. So there will be some favorable substance which responsible for superimposed infection. There will be the obstruction which is responsible for the impairs the clearance of secretion, and there will be superimpose infection to that, resultant inflammatory damage. So what happened then? In response to infection, our immune system will activate and it will recruit again the inflammatory cells responsible for the inflammatory damage also to bronchial wall. Yeah, to the bronchial wall. And the accumulation of the, to which what happened? Accumulating exudate. So there will be the accumulation of exudate. Further distend the airways. Further distend the airways. And this is the irreversible dilatation or permanent dilatation. Dilatation. Irreversible dilatation. So what we will see in morphology? In morphology, we will see that the airways are dilated 4 times the usual diameter. So it dilates 4 times than the usual diameter. As well as normal lung, normally what happens in normal lung, okay? In normal lung, if we put the probe, it stop 1 to 4 centimeter before pleura. But in bronchiectasis, it almost reaches to pleura. Okay, so this is the morphology of bronchiectasis. And what is the complications? What will be the complication? There is empyema. 3 things will happen. One is empyema. It could be the lung abscess. And there will be the amyloidosis, which is of A type. Amyloidosis. A type, right? And now we will see the clinical feature. So in clinical feature, we will see that there is a characterized by severe persistent cough with expectorant of mucopurulent, sometime fetid sputum. Okay, so what will happen? There will be the persistent cough with mucopurulent, with expectorant mucopurulent, right, which is fetid symptoms. Sometimes it could be the fetid sputum. This is the bronchiectasis. And there could be the dyspnea, rhinosinusitis, and there could be the, rarely or occasionally, there will be the hemoptysis, and obstructive ventilatory defect, hypoxemia, pulmonary hypertension, and core pulmonale. These are the things. So let's revise once. What is bronchiectasis? Bronchiectasis is nothing but it is the abnormal dilatation of bronchi and bronchioles with destruction of with destruction of bronchial walls. So what could be the causes? One is the Gardner syndrome. What is Gardner syndrome? It is primary ciliary dyskinesia, responsible for the male and female infertility as well. And then next one is the cystic fibrosis, bronchial obstruction and infection. Bronchial obstruction, infection, cystic fibrosis and Gardner syndromes. So usually it affects the lower lobe of the lung. It usually affects the lower lobe of the lung. So now the pathogenesis we will see. So what happened? Initially there is the obstruction, okay, which is caused by the foreign body or any other cause, and then it impairs the clearance of secretion. So whatever there is a bronchial secretion, it won't clear effectively, and then it causes the favorable substance for superimposed infection. So there will be the favorable condition and there will be the superimposing infection, and it causes the resultant inflammatory damage to bronchial wall, and accumulation of exudate further distend the airways and causes the irreversible dilatation. This is what is bronchiectasis. And morphology will see that bronchial walls are 4 times dilated. It is 4 times dilated than the normal ones. And in bronchiectasis, if we put the probe, it reaches up to the pleura, near to the pleura. What could be the complication? There will be the 3 complications. One is the empyema, lung abscess and amyloidosis, right? 3 things: empyema, lung abscesses and amyloidosis. What could be the clinical feature? The most important clinical feature, there will be the persistent cough with expectorant mucopurulent and the fetid spittle. There could be the dyspnea, rhinosinusitis, hemoptysis occasionally, obstructive ventilatory defect could be there, hypoxemia, hypercapnia, pulmonary hypertension, as well as the core pulmonale could be there. Thank you.